So welcome everyone. Good morning, good afternoon, good evening for our attendees worldwide. This is after Chang. I'm in Texas, United States. So it's almost like 4 o'clock in the morning. So I use this virtual background. You can see the nice, beautiful campus building. So today we would have this like a great live webinar, a conversation with experts. We'll discuss laboratory factors that impact embryo culture outcomes. We have 4 excellent speakers. The format of this webinar will be like a 10 to 15 minutes of talk from each of our speakers. They will discuss like a concept and also the common practice, standard practice, or oftentimes there is no standardization in our IVF lab practice. And also the myths and common like errors or some of the new ideas they would like to bring up. Then after that, we'll have about 30, 35 minutes or maybe even go longer if we have a lot of feedback and questions. And we'll discuss about what the audience think about and what the questions the audience would have. And also during one of the sections, Dr. Malhotra will bring up a poll. And he did a very nice study in India with similar topics, and he would like to get everybody's opinion on certain topics in the lab about the embryo culture into day 5, day 7. And also I would like to mention that this webinar is supported by an unrestricted educational grant provided by Fujifilm Orion Scientific. So we would like to thank Fujifilm for supporting this webinar and also a long-time supporter for ESHRE. So today we have 4 topics. We'll talk about the dry versus humidified incubators, like how much the stable temperature, pH, osmolality, how the critical factors about those, as well as day 5 to day 7 Blastocyst culture and vitrification. So nowadays we have a better system. Oftentimes we see there's a variety and variances among different clinics worldwide, in especially the Blastocyst rate, not just only the embryo conversion rate into Blastocyst, but also the good and top quality Blastocyst and also utilization of those Blastocysts. So how to make more and better Blastocyst, that would be the main topic for Dr. Malhotra will bring up. Then we'll discuss KPIs, key performance indicators in the ART labs. So Dr. Latif will talk about how to select meaningful indicators and set actionable targets. And Dr. Doshi from London, United Kingdom, will discuss a successful PGD program, key factors from embryo biopsy to outcome interpretation. So we can see that those are very like a broad spectrum of topics covering like majority of our practice in the IVF lab today. And we have more than 400 attendees registered, and we'll expect a very exciting discussion and exchange of ideas after the lecture. So first, I would like to introduce Professor Mio. He will be our first speaker discussing the dry versus humidified incubator. So I've known Dr. Mio for a long time. He's one of the pioneers in the world developing the time-lapse imaging system, and has won a lot of the video and also technology awards from SRM and other societies. That's where I met Professor Mio. I serve on the SRM video committee, and pretty much every year he will get one of the awards. Then I will hand awards or certificate to him. Dr. Mio is the chief director of the Mio Fertility Clinic, and clinical professor at Tottori University in Japan. Also, he is a editorial board member of Journal of Assisted Reproduction and Genetics. So let's welcome Professor Mio to bring up the first talk.
Okay. Thank you very much, Arthur. Long time no see. Today, I would like to give you a 10 minutes talk regarding dry versus humidified incubators. I have nothing to disclose in my talk. Although humidified wet incubators have been widely used for culturing human embryos, in recent years, many laboratories have started using non-humidified dry benchtop incubators equipped with time-lapse imaging systems instead, due to their small size and lower risk of fungal contamination. However, in vitro culture conditions are thought to be unstable and far from physiologically well controlled compared to in vivo culture conditions. Recently, we reported that the osmotic pressure in dry incubators increased much more rapidly and dramatically than those in the wet incubators within a 5 days period. Therefore, according to the type of incubator, dry or wet, we need to take effective measures as minimize changing culture conditions. In this lecture, I'll talk about the differences in maintaining temperature, pH, and osmotic pressure between wet and dry incubators. At the beginning of my talk, as introduced by Arthur, I would like to show you an in vitro culture system for time-lapse cinematography that we originally developed in 2003. Our research work was the first to allow physicians and embryologists to analyze dynamic morphology visualization process to hatching blastocysts. Since then, this research project lead to the use of dry benchtop incubators equipped with a time-lapse monitoring system. This is the first movie taken by our time-lapse system. You can see the whole process from fertilization to second cleavage in a human oocyte. A sperm located at the 5 o'clock attached to the oocyte membrane. 40 minutes later, fused into the ooplasm, and second polar body here, and fertilization cone here. Two pronuclei appeared and moved to the center of ooplasm, reached to the syngamy, then first cleavage occurred. Within a 40 hours observation, this embryo cleaved twice and developed to fossil stage. This embryo is still in liquid nitrogen. This is another first movie from the two-cell stage to hatched blastocyst. The mitotic division were repeated, then reached to Malhotra. Now going to Malhotra. And the embryo developed to blastocyst, and then blastocyst cavity expanded. You can see the inner thymus located at 10 o'clock. After fully expanding, collapse of cavity occurred and then zona cracked. The blastocyst escapes through the cracked side of the zona. This is the process of hatching in a human embryo. First of all, I'm going to focus on a change of temperature in a culture dish over time. This is a change of temperature in the bottom of culture medium using the thermometer with a 400 micrometer fine sensor. As you can see, once the chamber was opened and then closed, in both type of incubators, the temperature of culture medium rapidly dropped to 36.1 degrees Celsius in the water jacket type and to 36.8 degrees Celsius in the benchtop incubator. Then the temperature in both incubators gradually increased to 37 degrees, but the water jacket type took around 90 minutes to recover to 37 degrees, whereas the benchtop type recovered in 3 minutes. In terms of the stability of the temperature, benchtop incubator is superior. However, if the chamber is not opened in any incubator, the temperature is quite stable and is able to be maintained at an optimal range. This is one of the examples of temperature monitoring of benchtop incubator. How about pH in the culture media? As you know, it is essential to maintain optimal pH level during in vitro culture conditions. Swain reported on the change of pH in the culture medium with or without mineral oil. If you cover the mineral oil by, if you cover the medium by mineral oil, pH does not change for a long period of time. However, since pH in a culture medium with oil gradually increased over time, pH in dry incubator may change steadily because of the evaporation of water from the culture medium. Then I would like to move on to the osmotic pressure. This is our preliminary data regarding the change of osmotic pressure captured in wet blue line and dry red line incubators. Surprisingly, the osmotic pressure in a dry incubator red line significantly increased within a 5 days period, irrespective of the drop size. Around the same time, we found osmolality rise. Fozzi et al. Reported the difference in clinical outcomes between wet and dry incubators in 2017. They found that every parameter after ICSI, except for cleavage rate, was significantly lower in dry culture group than that of wet culture group. In addition, in clinical outcomes, the rate of clinical pregnancy, ongoing pregnancy, and implantation was significantly lower in dry culture than in wet culture. These results indicate that a dry culture has a negative impact for further development of fertilized oocyte in human ART programs. We further investigated the differences in culture conditions between wet and dry incubators and reported last year. In our report, we measured the osmolality in medium A, 50 microliter and 200 microliter covered by oil A among 3 types of incubators within a 5 days period. A and B incubators were dry, and incubator C was wet. As you can see, irrespective of media volume, osmolality in wet incubators showed only a little change within a 5 days period. However, in dry incubator A and B, osmolality in both 50 and 200 microliter media steadily and significantly increased within a 5 days period. Furthermore, as mentioned before, osmolality rise in a larger volume of medium was slightly restrained compared to osmolality in a smaller volume of medium. This is a comparison of osmolality rise among 3 types of commercially available media in a dry incubator. The pattern of osmolality change was exactly the same among the 3 media within a 5 days period. However, osmolality rise in a large volume of microdrop seems to be refrained when compared to that of a small volume of microdrop, although it is not statistically significant. According to those results, we investigated the relationship between osmolality rise and different types of mineral oil. You can see in oil A, C, and D, osmolality rise was significantly controlled compared to oil B. Oil A was washed. C and D were heavy, but oil B was a light oil. What is the difference in oil A, B, C, and D? The viscosity in oil A and oil B was smaller than that in oil C and D, which means oil A and B are light oil. In terms of water vapor content and water activity, it is shown that a washed light oil has similar properties to heavy oil. This is the results of osmolality of drops covered by non-equilibrated or equilibrated oil in a dry incubator. If you use equilibrated oil, osmolality rise is restricted. This is the Swain's data from 2019. These results are exactly the same as others. In conclusion, in terms of change in temperature and pH in the culture medium, there is no significant difference between wet and dry incubators if the mineral oil is routinely used to cover the culture medium. In terms of stability of culture conditions, humidified wet incubators are superior to non-humidified dry incubators. Taking into consideration the merits of dry incubators, you should try to minimize the rise of osmotic pressure. 1, use media with a relatively low osmolality. 2, use washed or equilibrated or heavy oil. 3, change culture medium on around day 3. Since in vitro culture conditions are always unstable and insufficient for embryonic development, we need to devote ourselves to developing more suitable conditions. Thank you for your attention.
Thank you very much, Professor Mio. I believe the audience will have some questions and maybe some troubleshooting. Will need your guidance later today at the webinar. Our next speaker is Dr. Malhotra. So I met Dr. Malhotra a couple years ago at the ESHRE as well as ESHRE meetings. He's one of the most talented young embryologists in the Asia, as I believe. He also, as Economic Times listed him as a budding embryologist of the year in 2019. And Dr. Malhotra holds a master's degree in clinical embryology and is one of the very few ESHRE certified clinical embryologists in India. He's currently the lab director of Rainbow IVF and the director of Malhotra Embryology Training Academy. He's on board of ISAR and ISPAD and has worked on multiple key projects pertaining to embryology in the country. For example, like the occupational standard for the embryologist and the embryology consensus. And today, Dr. Malhotra will bring the topic and discuss on the day 5 to day 7 Blastocyst culture and vitrification, how to make more and better Blastocysts. So I will pass the microphone to Dr. Malhotra.
Thank you, Professor Arthur, for that very kind introduction. A very good morning, good afternoon, and good evening to all of you here. It's such a wonderful platform that Aspire has actually brought forward to all of us. And again, a special thanks to Professor Mio for actually bringing up so many good points, which I'm also going to be highlighting in this presentation. Now, before we begin, I'd like to actually take you through a survey that we conducted. And again, before I go through those slides, can we have the polling questions so that we can actually compare the practices that all of you follow with the practices that are there in India at the moment. So you would be able to see a question at the moment. Please select your answer and submit. There are going to be 2 questions, and then we'll have another one at the end of this presentation. So we actually conducted this survey in India, and this was pertaining to the topic, which was day 5 to day 7 Blastocyst culture. Now, like all of you would know, generally we are culturing embryos till day 6. So it was kind of interesting to see what embryologists are following throughout the country. So the first question that we had in this survey was till what day do we culture embryos? And if you notice that out of almost 100 responses, we actually found out that 46% of them were culturing only till day 6, 37% of them were culturing till day 5, and day 7, if you look at the results, only 14% of the embryologists actually cultured till day 7. Now, again, when we talked about how to use such blastocysts, if you look at the results here, most of the embryologists and clinicians actually preferred, when they have a day 6 embryo, they would want to do a frozen embryo transfer. And when they have a day 7 blastocyst, they would prefer to discard that embryo. And almost 50% of the clinicians actually thought of discarding the blastocyst at day 7 and not doing anything else. Again, if you look at the apprehensions for not culturing embryos till day 7, almost 40% of them thought that these embryos have a poor developmental potential. 18% of them thought that they had low implantation rates. 23% thought that they had high aneuploidy rates. And again, we had 21% of them who thought that most of these embryos have poor morphology on day 7. And that's one of the reasons why they chose to discard the embryo. So looking at all of this, let's come to the background of this talk. Now, we all know that generally, when we're following the Istanbul consensus, we should have an expanded blastocyst by about day 5, which is 116 hours plus minus 2 post-insemination. Now, most of the embryos which are unsuitable at that point, or which are growing slow, or which are more or less on day 5, are actually cultured for 1 more day. And we should be actually observing these embryos at 138 hours post-insemination to check whether they're suitable for biopsy or cryopreservation. If you look at the guidelines that exist, ESHRE has recommended the committee opinion that you should culture blastocysts specifically till day 5 and day 6. And even the Istanbul consensus actually says that you actually culture the embryos till about day 6. Now, based on all of this, I tried to find certain papers which would be of significance to you. So the first one is actually from Dean Morbeck And this is a wonderful paper because this talks about the grading of the blastocysts in the era of PGS. And basically based on the results and outcomes of this paper and the kind of the meta-analysis that Dean did, it actually has to be noted that the developmental potential of day 7 blastocysts is very, very relative to the grade of the blastocyst. So if you have a good grade blastocyst at day 7, it would have a very nice developmental potential and it can still be utilized in a frozen embryo transfer. Now, again, if I go back to the Gardner system, we are only using a threshold of maybe, let's say 3 BB as the minimal grade for blastocyst usability. But that paper that I mentioned really questions whether we should be actually identifying certain blastocysts which would have more potential, now, especially if you have a poor responding patient where you're getting blastocysts on day 7. Dean actually mentioned in that paper that you can cryopreserve even C-grade blastocysts because they have also resulted in pregnancies. And again, for that specific patient, it might be the only chance because he or she might be advised to use egg donation in the next cycle, or they would not have like funds to go through with another cycle. So it's worth giving them a shot with a day 7 blastocyst. And again, I like this line from Dean's paper, and this is again, should extended blastocyst culture include day 7, and you can actually see a poll at the moment as well. So this line which says we actually crave simplicity and certainty, but blastocyst grading is neither. And in our pursuit of defining the best embryo to transfer, we've actually neglected to define viability of low quality and slow growing blastocysts. So this is something that we should be considering. Now, if I look at the outcomes from day 5 to day 7 blastocysts, this is a paper from John Whitney's group, and they actually looked at the ploidy status of day 7 blastocysts, and you can actually see that almost 35.9% of these blastocysts which were biopsied actually resulted in euploid embryos. And if you look at the live birth rates, they were quite good, even though the number is less, but having a 43% live birth rate is quite substantial for such patients who generally produce blastocysts on day 7, and those might be the only blastocysts arising from that patient. Again, this is the same data which is there, which actually signifies that ploidy, instead of actually depending on the day of blastulation, actually depends on the grade of the blastocyst. And AA, AB, and BA blastocysts actually showed better ploidy as compared to the others. So it's probably time to change our mindsets a bit. Now, let's look at our data. Now, this is my data from 2019. I don't do day 7 blastocyst transfers. And hopefully by the end of this webinar, I will start doing day 7 blastocyst transfers. But looking at day 6 blastocysts, I've had 25 patients in the last year where we actually did a day 6 blastocyst transfer. And actually, we had quite decent results. And when I compare it with day 5, obviously day 5 was better, but it's still a good enough chance for patients who are actually undergoing day 6 transfers. Now, we all actually know this phenomena, and this is quite rampant in current medical practices where it's like one size fits all. It's like one stimulation for all patients, which is being challenged quite a bit. It's like one embryo transfer strategy for all patients, etc. But we know that this cannot be held true for the in vitro fertilization situation. We know that each patient is different. We know the embryos from each patient is different. The culture conditions can be different. The medias can be different. There are so many factors that can actually affect the development of the embryo, the quality of the embryo, etc., etc. So I've just tried to summarize all of them. And these are some of my recommendations for making better blastocysts based on the publications that are present at the moment. So I tried to divide like making better blastocysts into 4 categories, which I feel are very, very relevant. Now, the first one is obviously the gametes and the gamete quality. And these are fantastic publications, which I would suggest all of you to read, which basically signify that obviously the sperm DNA quality and the sperm morphology based on Casanova's paper actually has a very high effect on the blastulation rates and the live birth rates. The oocyte quality, I'm sure all of you have seen Laura Rienzi's work, and that also is a determinant factor in blastulation rates, especially if you have multiple morphological defects. Those are the oocytes which would not perform better. Balaban's group actually had this paper on exposure during the procedures, And that also tells us that if you minimize the exposure, you're going to probably get more blastocysts. And that basically uninterrupted culture also talks about the same. And again, age of the patient is very, very important. So younger patients will perform better, older patients would not perform as well. Let's look at the culture conditions. Now, again, I tried to divide this into 4 important factors, which have been touched upon by Professor Meo's talk. But again, uninterrupted culture is something which is very important, and Jason Swain's paper actually talks about it quite a bit. And nowadays, the concept, even when people don't have time-lapse incubators, a lot of people are just checking the embryos on day 1 of fertilization and then just checking the blastocysts. Now, obviously, this is quite controversial, but these are practices which are coming up, and we really need to look at such practices in more detail. We all know the effects of oxygen tension and humidity, and again, having a humidified incubator with low oxygen tension will give you better blastocyst utilization rates. You also have to look at the culture suite that's present, and having a complete culture suite which is rich with essential amino acids, non-essential amino acids, etc., actually gives you better blastulation. And again, Professor Meo just talked about oil overlay, and that can also really influence the results. Let's look at the lab for a bit. Obviously, this is something that all of us know, but having low VOCs, low ppm, and low light exposure will improve the blastulation rates in the laboratory. And each laboratory has to be KPI driven. And Haroon is going to talk about this in the subsequent talks. But again, if it's a KPI driven laboratory, I will be very certain that that laboratory is probably producing more blastocysts than the others. And again, last is the skill of the embryologist, where it's the job of the embryologist to minimize the skill, the timing of the procedures, the skill with biopsy, and the skill with cryopreservation, which can all influence outcomes. Now, these are some recent publications where, again, this is the second part of the lecture where we talk about making better blastocysts, and this is just some add-ons which can influence those results. So the things that I could find out was, first was GM-CSF. Now, this has been there in the market for quite a bit, but again, when you look at the evidence, especially the Cochrane reviews, which this Cochrane review came up in 2020, and this basically says that there is very low quality evidence to suggest whether GM-CSF actually is better than just regular culture media. But again, if you look at the recent publications, especially on antioxidants, which are coming from Professor Gardner's group, both antioxidants in culture and antioxidants in cryopreservation media can actually help you in improving outcomes. And this is something which has to be looked forward to. And we need more literature and more meta-analysis to suggest whether this helps. Now, what about vitrification? This is also something which all of us need to worry about. Now, again, I tried to divide this into 4 aspects. The first one basically is blastocyst morphology. And based on the literature that's present, obviously the grading of the trophectoderm and the grading of the inner cell mass determines the survival of the blastocyst. It's also determined by the influence of early embryonic quality. So if the embryo is not dividing as per the required parameters which are set on the Istanbul consensus, we might not get the same kind of survival rates as we would get from a top quality embryo. The day of blastulation also governs this aspect, and also biopsies. Now, I'm sure Alpesh is going to talk about this, but cryopreserving blastocysts which have been biopsied is also a skill set which needs to be like, you have to get specialization in it, because you're creating a breach in the blastocyst, and depending on the kind of protocols that you're using, your time of equilibration might vary. Now, let's look at the cryoprotectants. Now, obviously, it has been mentioned that multiple cryoprotectants will give you better outcomes. Multiple equilibration steps will give you better outcomes. And the presence of certain macromolecules like phycol and even the antioxidants which are coming up might improve your outcomes. The device, open versus closed, open systems will give you a higher cooling rate, which might improve survival, but closed systems actually eliminate that hypothetical risk of cross-contamination. So it's something that you have to weigh the pros and cons and then decide upon. Cooling rates are very, very important. like I mentioned, open systems will give you better cooling rates, but it's also the load volume which determines the cooling rate. So whenever you're actually loading the blastocyst, try and take out all of that excess media, and that might also help you in standardizing your survival rates for blastocysts. And it's also the skill and comfort of the embryologist. Now, if I, as an embryologist, am not comfortable with a certain device, I might not get the same kind of survival rates with that particular device. So that's also something which I feel is very, very important. And based on the add-ons which are available now, blastocele collapse is something that a lot of embryologists do prefer when they are doing blastocyst vitrification. But again, it's something that like I feel I've not done blastocele collapse for my patients, and I get the same kind of survival rates as mentioned in literature. So I'm happy doing without it. But if you're doing blastocele collapse, obviously laser is something which is preferred. Now, what about day 7 blastocysts, and especially blastocysts which have been biopsied on day 7? Now, these are some of the publications which actually mention that the morphology of the blastocyst is very, very important. It's also important that you biopsy these blastocysts in order to get the best kind of outcomes. Again, the age of the patient plays a very important role as far as day 7 outcomes are concerned. And survival rates here are variable. So you have to talk to your patients, you have to counsel them that you would not get the same kind of survival rates as compared to a day 5 or a top quality day 6 blastocyst. So just to conclude on the day 7 recommendations, because of the uncertain outcomes, I think the guidelines that need to be developed here have to be relative to the age of the patient. So coming to the end of this presentation, again, this is from Dean's paper. And at the moment, it's very rare that you get day 7 blastocysts. So less than 8% of the cycles will actually result in day 7 blastocysts or sole day 7 blastocysts. But what has to be mentioned here is that some of these blastocysts are of top quality. And because of the advances in culture conditions, because of the advances in the incubator, we probably are in a position to say that we can actually get better outcomes, or at least some kind of good outcomes for patients with day 7 blastocysts as well. So I'd just like to end here with the poll that was there from India, where most of the embryologists who were participating did consider that maybe freezing day 7 blastocysts might be beneficial. But again, this is something that is up to you, and we can actually have a discussion on this later on. Right, so if I look at the poll results from this webinar, 28% of you actually feel that embryos should be cultured till day 7, 44% of you feel that maybe it's beneficial, and 28% actually feel that it has no benefit. But hopefully I have changed your mind a bit. So thank you all from Agra, and I'm looking forward to a fantastic discussion to follow.
Thank you very much, Dr. Malhotra, for this excellent talk. I would like to introduce our next speaker, Dr. Latif. Dr. Latif is one of the leadership executive board members of ESHRE, and I've known Dr. Latif for a few years and I very admire his leadership and also his practical approaches, not just in scientifically, but also the management skills. Dr. Latif will talk about the KPIs in the ART labs, select meaningful indicators and set actionable targets. Dr. Latif graduated from Bakwai Medical University and with a Bachelor of Medicine, Bachelor of Surgery, and obtained a Master's in Clinical Embryology from Monash University in Australia. He joined the Lahore Institute of Fertility and Endocrinology. That's with abbreviation named LIFE, so which he's a CEO right now, and is one of the leading ART clinics of the country in Pakistan. He is a lab director and chief executive of the clinic, and also he obtained his fellowship in sexual medicine and in a fellow European Committee of Sexual Medicine. So he also manages and runs a very successful sexual medicine clinic with a group of urologists and psychologists. He's a founding member of Pakistan Society for Embryology and Sexual Medicine and General Secretary for IVF Society of Pakistan. And recently, Dr. Latif completed his management diploma in healthcare from Harvard Business School. So congratulations, Dr. Latif. And let's welcome Dr. Latif for his talk about the KPIs.
Thank you, Professor Chang, for your kind words. And thank you for the ESHRE Education Committee for giving me this opportunity to present some work in this webinar today. My topic today are key performance indicators in ART labs, selecting meaningful indicators and setting actionable targets. It's a very broad topic, very difficult to cover in a short span of about 10 minutes. So what I'm going to do is I'm going to give an overview of the different performance indicators and the key performance indicators. And with that, I'll give some suggestions also and share some data. So when we think of quality, many things could come to your mind: quality brand, sports car, quality clothes, quality food. However, for me, I think a rainforest is a perfect example of quality of nature at its best. We all know that rainforests are responsible for life on Earth, and they're extremely important for the ecosystem. And hence, they have a perfect ecosystem, the kind of an ecosystem that we need in an ART lab. Obviously, to get these beautiful looking hatching blastocysts, a few of them Dr. Malhotra just showed, we have to have a perfect ecosystem inside the lab. And there's so many variables that need to address to get that ecosystem right. So until unless the lab is KPI driven, obviously it'll be very difficult to get these good results. ART, as we know, is very distinctive in nature. It is an extremely complex process. It involves multiple subspecialists in it. We have the embryologists, the clinicians, the lab technicians, as well as ART nurses, and so on and so forth. And all these specialists need to be highly skilled as lab professionals, as well as clinically as well. We know that there are multiple variables which impact the outcome of an ART cycle, even in the lab as well as in the clinical side. Another challenge is that there are different laws globally which govern ART practices. But luckily, there are guidelines available where we can refer to according to our own customized laws and work accordingly. Definitely, ethics is an integral part of an ART clinic, of an ART practice. When you talk about total quality management or total quality management in an ART lab, obviously quality management depends on a number of factors. A few years ago, to be exact, in 2012, the Alpha Group, and then in 2016, the ESHRE Special Interest Group of Embryology with the Alpha Group got together, sent out these surveys about quality control and quality assurance in ART globally. And what came out from that consensus is called the Vienna Consensus, which is a report of an expert meeting on development of ART lab performance indicators. I think this is an excellent report, a complete comprehensive report giving an insight on the KPIs. What they identified was that there are three main indicators as far as ART is concerned. There are reference indicators, which are actually proxy indicators of the oocytes coming inside the lab. So they do not reflect the kind of work which is going inside the lab, but in fact, this is the response to the ovarian stimulation protocols being used from the clinical side. Then there are performance indicators, quite a few indicators, but these are documented and stored regularly. However, they are not referred to in a control group regularly. So you don't go back on regular basis and check on them that how things are in the lab as far as these performance indicators are concerned. Now, the core business of an ART clinic or an ART lab are the key performance indicators. And any lab that has to be driven by these key performance indicators will end up getting good results. Another thing the Vienna Consensus explained was that there has to be a minimum competency level. The minimum competency one has to have to get good results. And there has to be a goal as well, an aspirational goal, which they named it as the benchmark, which an ART lab should try to achieve. Coming to the reference indicators, as I mentioned earlier, that these are proxy indicators. They involved the proportion of oocytes that are recovered over the number of follicles on the day of the trigger. The benchmark set was 80 to 95% for them, and the proportion of mature M2 oocytes at the time of ESHRE. The benchmark for this is established to be around 75 to 90%. Now, coming to the performance indicators, as I mentioned, these are the indicators which are documented and stored in an ART clinic. However, these indicators are not referred to regularly. Obviously, these indicators include the sperm motility, post-preparation for both IVF and IUI cases. It also includes the polyspermy rate in IVF and the 1PN rate in both IVF and ICSI cases. The good blastocyst development rate, and an extremely important performance indicator where the competence value is said to be at around 30% or more, and the benchmark is said to be about 40% and more. Now coming to the core business of the ART, these are the key performance indicators, basically. These key performance indicators can be divided into 5 components, broadly speaking. Obviously, first component is the fertilization rate. It could be the normal fertilization rate, the failed fertilization rate, or the ICSI damage rate. The embryo development rate for both cleavage and blastocyst stage embryos, the cryosurvival rate, and for our PGT cases, the embryo biopsy, the successful biopsy rate, or as we call it, the tubing rate, is an important. I think Dr. Toshi is going to talk about it later on in the next presentation. And of course, the implantation rate for both cleavage and blastocysts. So these are the KPIs that need to be documented on regular basis and addressed to them so that your lab is a KPI-driven lab. As I mentioned, there's a long list of it covering all the routine aspects of what work is going inside an ART lab. Just to give you an example, for example, normal fertilization rate, the competence value has to be more than 65%. When you talk about blastocyst development rate, it should be more than 40% or equal to, and setting a benchmark of 60%. So a very important aspect is that you have to have these benchmarks which are practical also. You can't set a benchmark of 100% fertilization rate, for instance, which is very difficult to achieve. You may set it at 80% 1 year, and once you achieve it, you can take it up to 85%, 90%, and so on and so forth. So obviously the competence levels are there, but once you're deciding for your benchmarks, obviously they have to be very practical also, and not something which is not achievable. Out of these KPIs, I would imagine that one of the most important KPIs, which has a huge impact on your clinical pregnancy rates and live birth rates, are your implantation rates as well, for both your cleavage stage embryos as well as for your blastocysts. So what do you do with all this information? Obviously, you chart it. You can use a control chart, for instance. A control chart has a central control line on which you would like to stay as far as your indicators are concerned. And depending on what type of indicator are you looking at, you may exceed the upper limit, or you may come down from the low limit. So you have to put this data in these charts so that you can monitor the trends inside the lab, and so that you can preempt before you go out of range. So what are the factors that impact these key performance indicators? An excellent publication which came out recently in January 2020 in RBM Online. Obviously, it's called the Cairo Consensus Guidelines on IVF Culture Conditions. And I love the statement. It says there is only one thing that is truly important in an IVF lab: everything. As I mentioned in the beginning, there's so many variables to it. So obviously, even if one part of the puzzle is missing or is lagging, then obviously you're not going to get your desired results. So looking at the Cairo Consensus, look at the ideal culture system. And again, a lot of components that are involved to produce those beautiful looking hatching blastocysts. Some of the components I've highlighted over here, such as the gamete handling, obviously extremely important. your gases, your CO2 concentration, your culture of embryos and low oxygen concentration levels, the physiochemical conditions that has to be maintained and optimal throughout the procedures. Temperature is extremely important, as we all know. Your culture media, whether you're using a single step or a serial media, appropriate storage of the media and related things are important. Obviously, micromanipulation, which is heavily operated dependent, is also extremely important. And then, of course, your equipment, what kind of incubator are you using, what kind of calibration and washing is being done regularly and not, and so on and so forth. This excellent publication by Haroon and Dean Morbach, which was published back in 2019, I think, but he also presented, I think Dean Morbach presented a webinar in ESHRE this year on this. And what they did was they wanted to find out, the question was that can embryology KPIs detect shifts in lab performance that precede changes in clinical outcome? So what they found out after doing this multi-center study, that day 5 usable blastocyst rate, D5-BUR, is an important embryology KPI that complements the total usable blastocyst rate in its ability to rapidly identify adverse embryology outcomes prior to changes in clinical outcomes. They used different medias to do this survey, and they found out that the change in media resulted changes in the lab. However, those changes was translated a few months later clinically. So this is a very important piece of information and one of the great examples how you can use your KPIs to preempt any adverse events in the lab and then which has an impact clinically. Just to put things in perspective, each oocyte or each embryo is manipulated about 20 times in the lab. So if you're running an IVF clinic, let's say if it's doing 200 cycles per year, there are about more than 20,000 manipulations in that lab in a year. So that's a huge number. And hence, so many manipulations, adverse or events are meant to happen. We can't be 100% correct. However, the target of having these KPIs is to control the percentage of these adverse events, to avoid serious adverse events, absolutely, such as loss of a whole cycle, and obviously should be KPI driven. The incident reporting, again published in Human Fertilization Embryology Authority of the UK. As you can see, there are very wide variables involved in it, many different types of incidents that can take place in an ART lab. And of course, some could be minor and some could be major, and we can avoid these major incidents. Obviously, the ultimate KPI would be a live birth rate, which may be considered the ultimate KPI for checking IVF lab performance. And it is defined as a likelihood of a baby to be born per embryo transfer. So what we need to do is, my suggestion is that obviously we need to personalize and set attainable targets for our own lab. Every working environment lab is slightly different from the other one. So we have to have our own reference patient population. For instance, in the Vienna consensus, it was recommended that you only look at the population where female age is under 40, they're using their own oocytes, no PGT cases, and all kinds of insemination methods. But then you can define your own reference patient population depending on what kind of set of population you're dealing with and what kind of infrastructure you have, and set up your own achievable KPIs, benchmarks, and the other things. So obviously, my final thought is that we can't, as embryologists, we can't have our heads in the sand. It's a never-ending struggle to maintain the quality and produce good results while keeping high patient satisfaction. So a strong total quality management system is critical for success in an ART lab. Thank you.
Dr. Latif, for this great talk. And like many people said, like we can collect a lot of data, but how to convert that into meaningful information is the key. And Dr. Latif definitely brought up a lot of insights, and I believe we'll have more to discuss during the Q&A section. I would like to introduce our next speaker, Dr. Apesh Doshi from London, United Kingdom. And Dr. Doshi will discuss a successful PGT program about the key factors from the biopsy to outcome interpretation. Dr. Doshi is a consultant clinical embryologist and also co-founder of IVF London. He is also co-founder and director of the Embryology and PGD Academy. He previously worked at the Center for Reproductive and Genetic Health in the leading capacity as the Director of Embryology for 19 years and was very pivotal in the optimizing success rates. He's also honorary consultant at the Reproductive Medicine Unit at the UCLH NHS Trust in UK. And he holds a postgraduate degree in human reproductive medicine and has qualified from the very prestigious Imperial College School of Medicine. And Dr. Doshi is a ESHRE certified senior embryologist and also executive committee members of several international embryology societies. And he has a very strong and advocacy in promoting the education platform through those professional bodies. And he has also several papers in high impact journals and also as a guest at the TV shows in UK as well. So today he will talk about the successful PGD programs and the key factors.
Thank you for that kind introduction and obviously the opportunity as well to present at the Aspire webinar. Absolutely delighted to be here, and today I'm going to be talking about a successful PGT program. By training, I'm a clinical embryologist, and I have a very active interest in PGT and embryo biopsy. So I'm not going to be talking much about the other stages of embryonic biopsy, such as polar body biopsy or cleavage stage biopsy. I'm going to dive in straight into blastocyst biopsy because this has pretty much become the gold standard now with any kind of PGT testing. So talking about blastocysts, we know that there are two components of blastocyst biopsy. One, which is the zona drilling, which is opening the zona pellucida up to take some of the cells of the trophectoderm layer. And the zona drilling can essentially be done on day 3, day 4, or day 5. So depending on the protocol and the choice of the embryologist, they can either perforate the zona with a laser on day 3, which is what I prefer to do, day 4 or day 5. Many embryologists take the view that they go straight to day 5 so that they know where the inner cell mass is and then make the opening on the opposite side. So that's a personal preference. The whole idea being that at the blastocyst stage, the embryo has differentiated into the two cell lineages, namely the inner cell mass and the trophectoderm. And through this opening that you make, hopefully you have a good few cells that are herniating out of the embryos, and you can excise about 5 to 7 cells out of the embryo from the trophectoderm layer in order to genetically test them. Now, to focus on a bit of the pros and cons of blastocyst biopsy, of course, the benefits being that you take a larger number of cells compared to cleavage stage biopsy or even polar body biopsy. In the grand scheme of things, it's still a much smaller proportion of cells compared to doing a cleavage biopsy. For example, if you're going to be taking 1 or 2 cells out of a cleavage stage embryo, then you're essentially taking a quarter of the embryo out. So we know that cleavage biopsy does have an impact on implantation rates and blastocyst formation rates, whereas blastocyst biopsy has shown no impact on implantation rates compared to control population. And this was a very good study done by Richard Scott's group. So the drawbacks being, we've heard excellent talks today about KPIs. And of course, one of the main impact factors when it comes to a good PGT program is the blastocyst formation rate. Especially because everything has now moved towards blastocyst biopsy, we need to make sure that our lab is capable of forming good blastocysts. And all the talks that have been presented this morning, right from Professor Mio, from Keshav Malhotra to Professor Haroon as well, all of these have focused on key performance indicators to optimize blastocyst culture, cryopreservation, and so on. And all of these form the framework of a good PGT lab as well. Because if you do not have a good blastocyst formation rate, you are not going to have a good PGT output in terms of the number of embryos biopsied, in terms of potentially the results as well. And we all know that even all these culture conditions that we have talked about also affects mosaicism in the embryo. So this is just a pictorial diagram of when the opening can be made. As I said, it can either be made on day 3 or day 5. The aim is for the blastocyst to herniate, and then we take some cells or excise some cells from the embryo. Here we have a video of a blastocyst biopsy. So this is just a nice balloon herniating out from the zona pellucida. And what I'm doing there is I'm just applying some laser shots to dissociate some cells away from the embryo. And you'll see that when I apply the laser, there is a natural response of the cells dissociating from the remaining embryo. Here we go, and we've taken a nice small clump away from the embryo. Once we demagnify the picture there, you will see that there's a nice small clump. That is the remaining embryo, and there's a small nice clump that is going to be seen just in a second. So here we are, that's the embryo itself, with the inner cell mass quite intact, and you can, you could see, sorry, anyway. This is another video on what we would do if the inner cell mass is herniating out. So what we would do in such a case, we will have to make a second opening, especially in clinics like ours, whereby we make the opening on day 3. There is a chance that the embryo may be hatching from the inner cell mass. And if that happens, we may have to make a second opening. And there we are. I've just forwarded the video a bit, and you can see that a second opening has been made, and we are just going to be biopsying some of the cells from the second site by applying some laser shots to the embryo and dissociating the cells in that manner. So there we are. The laser shots have started to be applied, and the cells are going to be pulled away from the embryo. This slide was, the courtesy of Pacific Fertility Center, and obviously we have adopted our program to do something similar now, rather than letting the embryos totally hatch out. There we are. So that's the biopsy taken when the inner cell mass is hatching out. So we all know that one of the biggest problems or culprits with PGT is mosaicism. And we know very little in terms of how to interpret mosaic embryos. And although there are some guidelines coming out, such as one from PGD International Society, and I'm going to be talking a bit more about that later on. We all know that mosaic embryos, depending on the degree of mosaicism, do hold implantation potential, especially if we are testing for comprehensive chromosome screening. So embryos can either be totally euploid, can be totally aneuploid, or could be mosaic aneuploid, whereby the mosaic or the abnormal cells are infiltrated throughout the embryo, including the inner cell mass. Obviously, the implantation potential of these totally mosaic embryos can be lower, or would be speculated to be lower, than the embryos whereby there is mosaic cells in the trophectoderm, which may naturally be a mechanism of the embryo throwing out aneuploid cells towards the trophectoderm in order to keep the inner cell mass clean and clear of those aneuploid cells. And one believes that it is such embryos that may give rise to healthy offspring, despite having mosaic cells in the initial analysis. So we know that we can get up to 33% live birth rate from these mosaic embryos as well. And Francesco Fiorentino's group has demonstrated that quite well from a huge amount of data set. So now next presentation is going to be more about how do we interpret PGT results. So if we look at PGT-A, for example, it's very straightforward. You can either have a euploid embryo, you can have an aneuploid embryo. We can either have categorization of the embryo whereby it's categorized as a low mosaic. And of course, this is when there is 30 to 50% of cells are aneuploid in that embryo. Or it can be categorized as a high mosaic, whereby 50 to 70% of the cells are aneuploid. It could be a complex aneuploid, meaning 2 to 5 aneuploidies are detected. It could be a chaotic embryo, whereby more than 6 aneuploidies are detected. Or one of the outcomes could be that there is no DNA detected, or it's non-informative, whereby a rebiopsy would be required. This is a typical example of how a PGTA report would look like. And you can see how it is essentially categorized for this patient, whereby it exactly tells you whether there is a loss or a gain of a chromosome. It tells you whether you can transfer or not. And of course, whenever you have embryos like this, where it says low mosaic, you would need to seek genetic counseling before this embryo is considered for transfer. Now, again, this paper has shown a very good model on how to prioritize embryos for transfer if at all there is no euploid embryos available. And of course, you know, the aim of this is that you should try and totally avoid any mosaicism of the what we call the lethal trisomies, such as 13, 16, 18, 21, X and Y. So it would, certainly from our clinic perspective, our policy is that we would only consider transferring up to low mosaic embryos whereby there is no trisomies of the lethal chromosomes involved, such as 13, 16, 18, 21. So then we moved on to PGT for structural rearrangement. And of course, the nomenclature for results is whether it's a normal or a balance, whereby correct number of chromosomes are present. However, you cannot determine if the embryo has a balanced translocation. Or you can have an unbalanced embryo, which clearly indicates that there is an extra bit of chromosome sitting on one of them, and these embryos are potentially going to be not recommended for transfer. You can also test for aneuploidies, because the platform nowadays, whether it's next generation sequencing or high resolution array technology, you can screen for other chromosome as well. Like the previous slide, you can have low mosaic, high mosaic when it comes to the other aneuploidies, complex aneuploid, chaotic, or non-informative. This is an example of a patient of ours who had a structural rearrangement of chromosomes. And again, you can see that you can have events whereby you have unbalanced, so these are affected embryos, or you can have a normal stroke balanced embryo, meaning when I say that, it means that you cannot tell whether this embryo has the same translocation as the mother or the father who carries that balanced translocation. So the offspring may have the same translocation or maybe normal. So then we move on to the PGT-M, and of course the various categories are, you can either have an affected embryo, whereby they have at-risk haplotype seen, or you can have an unaffected embryo which does not have the at-risk haplotype present. You can have an abnormal embryo, which of course is unsuitable for transfer when it comes to the aneuploidies, or the other categorization is normal embryo when it comes to the categorization for aneuploidies as well. So here we had a patient where we did a PGT-M for a dominant, autosomal dominant disorder for multiple hereditary exotosis, type 1. And you can see how this embryo here, there was the gene found for the above disorder in 2 of the embryos. And again, it was affected for the dominant gene. And you can see that it's even being tested for the chromosomal aberrations, such as in this embryo, there is a excess of chromosome 18. This patient had one embryo that was normal, whereby the haplotype or the gene, affected gene was absent, and also no chromosomal errors detected, and hence one embryo is suitable for transfer. And again, I want to then talk about PGT-M for recessive disorders. Same thing, affected embryos whereby you can have at-risk haplotypes from both parents, and one such example is beta thalassemia for a recessive disorder. It must be said that PGTM nowadays is done by a technology of carrier mapping. You can also have a carrier status in these embryos, whereby, again, phenotypically, they would carry the same phenotype as the parents involved. Or you can have a totally unaffected embryo, and 50% carrier status, 25% unaffected, and 25% affected status. Apart from that, you would also get the results on comprehensive chromosome screening, such as the aneuploidies. So here is an example of the beta thalassemia report for one of the patients. You can see that there is maternal haplotype, paternal haplotype, and in two of these embryos, we could not transfer. One, because there was amplification failure in the stop embryo, so we would potentially have to rebiopsy that embryo. Embryo number 4, there was both the paternal and maternal haplotype present, so it was an abnormal and an affected embryo. Embryo number 5, again, is totally clear. It is not a carrier. It's clear from both maternal, paternal, and also chromosomal abnormalities. So this embryo can be considered for transfer. Thank you so much, and open it up for any questions. I'll hand over to Professor Arthur. Thank you.
Thank you so much, Dr. Doshi. Yeah, that's an excellent talk with a lot of information. So the first question is, I believe this is for Dr. Malhotra. And what is your opinion on vitrification at 37 degrees Celsius?
So I think Ashok asked that question. So thank you, Ashok, for that very interesting question, because this is one place where there's a lot of variance which would exist between embryologists. So if I go to the physical characteristics at this point, it's worth noting that both equilibration solution and vitrification solutions are toxic to embryos. And when we do vitrification at 37 degrees, the toxic effects are potentially higher. And that is one of the reasons where I would suggest that if you are doing vitrification at 37 degrees, the time has to be optimized. My personal experience is that I use room temperature for oocytes and room temperature for blastocysts. For cleavage stage embryos, I do use 37 degrees the equilibration temperature, but my freezing time is equilibration time is about 5 minutes. Now, I just read a very recent publication which came out in Nature, and this is last year's, and they are actually suggesting doing vitrification for oocytes at 37, where there's an ultra fast equilibration of only 2 minutes. And that's something that can be worth researching on. I also know from a fact that once you're biopsying embryos, these blastocysts are generally equilibrated at 37 degrees. I've seen protocols where clinics actually use a 2 to 3 minute equilibration time at 37 degrees and then vitrify them. So it all depends. If you're using a 37 degree temperature, your time to equilibration has to be lower. But if you're using room temperature, the equilibration time is a little longer, and that's the only thing that you have to worry about.
Thank you. So also, I would like to emphasize that oftentimes the manufacturer will have the suggested protocol. Yeah. So yeah, so we should always read the manual. I know sometimes I many people, we just go ahead and not checking the manual though. Either we use a microwave or in the lab though, but follow the manual. And oftentimes the same manufacturer derive a different a medium, then they will have a different instruction. Yeah, especially sometimes for even the eggs, the embryos might require different. Yes, Dr. Malhotra.
So for all young embryologists, I would say that you should stick to the protocols that are mentioned on the manufacturer guidelines. For the senior ones out there who've had work that they've done in research, etc., those are the ones who actually try and optimize the protocols based on their experience. But again, for all youngsters who are starting up, please stick to the protocols.
Yes, definitely. The next question would be for Professor Mio. So the one of the audience asks, if I have a dry incubator in a lab, does it help to humidify it by placing a dish with sterile water, or am I better off using a more dense mineral oil?
Yeah, thank you very much for asking me. I think sterile water in the dry incubator evaporate very quickly, so it is not so effective. I think that the dense oil is much more effective for maintain the osmolality. In addition, I think you should change the culture medium around this culture day 3. It's very important, I think.
Yes. So yeah, also that answer the second question from the audience, also like a change in the medium instead of the change on day 3. And could you go to the day 5? What's your recommendation? Like a day 3 or just go to day 5?
Yeah, I think you should change the culture media around day 3. It's to avoid osmolality rise, affect from osmolality rise.
Thank you. And the next question is for Dr. Doshi. Do you use laser, when you use laser biopsy, what size of laser pulses do you prefer to use? And also, do you have an opinion on flicking technique? And that's also one of my questions, not just the laser pulse, and also how big the hole do you drill from day 3? Yeah.
So the strength of the laser really depends on the manufacturer of the laser that you're using. So they could be lasers which are 150 milliwatt lasers, or you can have lasers which are 400 milliwatt lasers. So the relationship is inverse. If it's a 400 milliwatt laser, then you use a lower pulse irradiation time. We call it PIR. So for 400 milliwatt lasers, you use typically 0.2 or 0.3 microseconds. So it's not a very easy answer. Again, I would say that you need to seek the opinion of the manufacturer of the laser, because it could be 150 milliwatt or it could be 400 milliwatt. If it's 150 milliwatt laser, you need to then increase your millisecond exposure. If it's a 400 milliwatt laser, then you need to lower the millisecond exposure, because ultimately this relates to the amount of energy dissipated at the embryonic level. What was the other question? Was about the size of the hole. Typically on day 3, I make the opening around 10 to 15 microns of diameter. This allows a good streamlined layer of trophectoderm herniating out without risking the whole embryo coming out when you're pulling the cells. So I like making the channel a bit narrow and still big enough for the cells to herniate out and not risk the whole embryo coming out, which would then pose a further risk during cryopreservation, stickiness, etc.
And how about the flicking technique? What's your opinion on that?
I use the flick technique a lot. The flick technique means that when the laser is not going to dissociate the cells easily, so we know that a laser is a gun. A laser is a gun. So we need to treat it with a lot of caution, because embryos feel the heat and those cells can lyse as a result of the laser. So beyond a certain number of laser shots, if the cells are not coming out, it's easier to just flick. So what the flick means is that you release the embryo from the holding pipette, you hold the biopsy or the small amount of clump of cells that you have got in your biopsy pipette, and you use the holding pipette to shear off the cells and flick it, literally, as the name suggests. You use those few cells that are in your biopsy pipette to flick against your holding pipette. I've got beautiful videos on it, which I can show if time permits, but I understand the time is an issue. So yes, that technique works beautifully well. Again, it may sound traumatic and also look traumatic when you are actually flicking those cells off. But again, what is more detrimental? Keeping on hitting laser shots, which is damaging the cells, or a sharp short cut, which is the flick technique.
Great. And actually, I have a follow-up question regarding the laser. So oftentimes we have to do like a day 5, even though, for example, like I do day 3, like a laser drilling also, the zona drilling as well. But oftentimes we see some embryos like they will like grow out, and on day 5, and maybe the hole we drilled on day 3 are on the ICM, so I have to drill from the other side. And oftentimes some labs, they will do day 5 exclusively. So is there any suggestion on how to do that? Because the zona thinner, then you have those mural trophectoderm cells attached. What's your advice on perhaps in day 5, like drilling day 5?
Like you, Arthur, I prefer making the opening on day 3. And my reason for that is that the cells are not, when an embryo is under the pressure from the zona pellucida, then the trophectoderm becomes very tight and cohesive. But when there is an opportunity for the embryo to start herniating out through a breach in the zona pellucida, the biopsy becomes much easier. I feel that when I'm actually cutting cells from an embryo which has got an opening made on day 3, then it's like passing a knife through butter, whereby literally the cells come off very easily. But I appreciate that there are a lot of times we have to do PGTA on frozen embryos because the patient hasn't been pregnant or for various reasons. In such cases, I have to end up making the opening on day 5 after thawing. I usually find that biopsy becomes a bit more difficult because these trophectoderm cells are very tightly cohesive. And I end up using the flick technique a lot in these embryos where I haven't made an opening on day 3. But perfectly both viable strategies, and it's on personal preference.
Thank you. So we have a few questions regarding biopsy, but I will move to Dr. Malhotra first. So there's a question about like, what's your opinion on the minimal and maximum volume in vitrification?
So thank you to Malhotra for asking that question. Malhotra has been my teacher, has been my professor back at Monash, and again, Haroon is also one of his students. Now, that's a very interesting question, solely because this is also a point where a lot of embryologists vary. Now, my first answer here would be that it's best to follow the protocol and the manufacturer guidelines based on the size of the droplets that you're making. Now, like I was mentioning in the previous question, if you're actually vitrifying embryos at 37 degrees, that's where the volume would play a more major role, because at 37, the media evaporates and there's going to be more osmolar changes on the media. So in those situations, I would actually recommend having more volume media, or maybe following the manufacturer guidelines at that point with regards to media, the media volume. But if you're doing it at room temperature, in those situations, the stress of evaporation is going to be lesser. So if I talk about like developing countries, and that's one of the areas where people tend to save up on vitrification kits and vitrification media. In those situations, you might want to create smaller droplets, but I would not recommend going below 200 microliters. That's my personal preference. I would not want to do that, even if I'm doing it at room temperature. And again, the second thing that I would like to advise at this point is that obviously these protocols require a long time. So I would recommend that you only create the drop that you're making. So if I'm equilibrating embryos, I'll only create the equilibration drop at that point. I'll not create the vitrification solution drop at that point. So that will also help me in minimizing the stress, especially the osmolar stress, which would occur because of evaporation. So this would be my answer here. Nothing less than 200. Maximum is obviously your manufacturer guidelines.
And that's excellent point. Yeah, and I want to say that not just in developing countries, even in United States, a lot of clinics want to save that for the cost. You know, so 200 microliter would be your recommended minimum. So I have actually myself, I have a question for Dr. Latif about KPIs. So sometimes we have to change more than one factors in the lab. For example, we change medium. Maybe at the same time we have a new filter installed, or we have a new embryologist being trained. So how do you compare those numbers from the historical data? Then also the second question would be, would you suggest to do KPI on individual embryologists, or you think that's too going too far and excessive?
Thank you, Professor Chang, for the question. I was thinking that maybe my presentation is so good that I didn't get any questions. So thank you for asking me a question. The thing is, there's so many variables, as I mentioned during my talk, in ART, especially when you look at the key performance indicators, that if we don't, if our eye is not on the ball, then obviously there'd be changes, slight changes in your program, and before you realize it, it'll be translating into your clinical pregnancy rates and the live birth rates. So I think a good thing to do is do not change a lot of things at the same time. So if you want to make changes, just go one by one. That is the best. Obviously, there are instances, then obviously 2 or 3 variables come at the same time. However, a good practice would be to just go step by step. For instance, if you want to change your media, which is like a huge change, then you shouldn't be like getting a new embryologist in and letting him or her do the work while there's a new media in the lab and so on. There's so many examples for that. So in my opinion, obviously one change at a time. You do the change, you wait for some time. Like I mentioned in Dean Morbeck's study, that they actually saw the change in the clinical results 3 months after what they saw in the lab. So at times it takes a very long time to see that change. And by the time you see that change, obviously, you may not be able to trace back what the actual variable was. So this is very important. Sorry, what was the second question, Professor Chang?
Would you, so from the manager's perspective, would you suggest like a running KPIs on individual embryologist? Or do you think that's like too much, like too detailed?
So absolutely, I think work in IVF lab is heavily operator dependent, and obviously you have to have run KPIs with your new embryologist as well coming in, and as well as your senior embryologist as well. So one should always have that data in the lab. Should look at it depending on what indicator are you looking at. You can do it weekly, you can do it monthly, or even quarterly, depending on the indicator. And each embryologist's work has to be documented. And then if someone is lagging, the fertilization rates are different from the other colleagues, and obviously we can look at the skill set and go back. For instance, when a new embryologist comes in, it depends on your own lab's SOP. You might give him around 50 supervised cycles before that person can work independently, or 100 supervised cycles before that person can work independently. Then obviously there are different steps from oocyte retrieval to actually getting on to ICSI and PGT. So like I said, that you have to customize your SOPs, your key performance indicators should be according to your customized SOPs.
Thank you so much for the advice. Dr. Mio, so I actually have a question. People are talking about embryo collapsing. So we see more of those embryo collapse, like a re-expansion during the time-lapse imaging, which because time-lapse imaging gives us the continuous monitoring on those. So we see more often on those. Is that a good thing or bad thing, or does it matter if an embryo collapses a lot during blastocyst development?
Yeah, basically, I think Brussels collapse is negative, has a negative impact in development embryo development. But I don't still reach to conclude what type of collapse is bad, what type of collapse is not so bad. I'm not sure about this.
Yes, I believe that a lot of us still don't know the actually the answer for this one, because yeah, it's a very interesting topic. Then yeah, we will expect maybe some of the audience will bring up the research and show us later. Yeah.
Thank you.
And also the question about the re-expansion for the blastocyst. This one for Dr. Malhotra. Do you think the re-expansion after the FETs, like thawing or warming, so is that critical, or would you suggest that just immediate transfer after the thaw?
Okay, so my personal preference is that I wait for about an hour post warming, and most of the times we get re-expansion within this 1 hour. But even if you don't have re-expansion and the embryologist has assessed the quality of the cells that is present, and there's no lysis or there's no degeneration, it should not really make much of a difference as far as the results are concerned. There was this paper that I was reading while I was making this presentation, where especially after laser, so if you're doing an artificial collapse, these embryos actually tended to re-expand quicker as compared to a normal blastocyst or a blastocyst which has not undergone collapse. So that might also be a strategy for you if you're worried about it. But honestly speaking, I haven't seen any differences when I've transferred a collapsed blastocyst to when I've actually transferred an expanded blastocyst within that 1 hour time period.
Can I ask 2 questions?
Yeah,
sure. Yeah.
For Keshav, 2 things. First, do you have experience at making opening in the zona post vitrification, and what is your view on hardening of the zona pellucida as a result of vitrification and all thawed embryos needing assisted hatching? And secondly, you made reference to doing day 6 transfers in your setting. Now, again, the view here is that we avoid day 6 transfers totally, and that if you have embryos on day 6, then we vitrify them and then transfer them in an FET cycle. But you seem to allude to the fact that you do fresh transfer. No? Sorry.
No,
okay.
I'm sorry. So those were day 6 FETs, where the blastocyst was at day 6, but it was transferred at day 5.
Perfect.
So I'm sorry if I've missed it or missed that during the presentation.
And your view on
for your first question, like we were very for laser a couple of years ago, and then we started looking at our data. The implantation rates were better, but the multiple pregnancy rates were higher. So looking at that phenomena, we have switched over. So we generally, for blastocysts, I don't do laser anymore. For cleavage, I would still do a laser and I don't do a full breach. I'll just create a partial, I'll just thin the zona partially. The only place where I use laser, like for the only indication that I'm convinced in using laser is if I have a thick zona pellucida. And in those cases, I would recommend it. But otherwise, like based on the newer data that I also have, it's actually there's no difference.
So I have two questions from the audience for Dr. Doshi here. So first, may I know why we choose to biopsy trophectoderm from placenta, which will form placenta but not inner cell mass, which will form fetus for PGT? And also the second question is, what's your opinion on non-invasive PGT comparing with the embryo biopsy PGT? And the focus will be on the embryo damage and the PGT results.
So both very, very good questions. Currently, as the technology stands, whereby PGT is still done by an invasive process, such as a biopsy, we understand that we are trying to look at the inner cell mass and the health of the baby. So why are we biopsying the trophectoderm, especially when we know that confined placental mosaicism exists? To a certain degree, I believe we are all mosaic. You know, that there's always going to be mosaic cells in our body, and why not at the embryonic stage? So biopsying the trophectoderm, is it giving us the accurate indication of what the embryos are doing? Are we throwing away healthy embryos? And the answer is yes. In my opinion, I think we are throwing away healthy embryos. However, technically, it is very difficult to biopsy the inner cell mass. So if you have to go in to get the embryo, if you have to go in to get the ICM cells, it will damage the whole embryo because the size of the perforation that you need to make in your embryo is much larger, and your trophectoderm will not be able to repair that large size of puncture. Now, some studies have looked at using something like an ICSI pipette to go in and take some cells out. And again, the success of this has been very, very limited. So by and large, trophectoderm biopsy has become the gold standard. However, going to the next question, yes, this is linked to the fact that inner cell mass is more valuable. And with non-invasive PGTA, things are moving on quite well. I believe that we are pretty much at 86% concordance at the moment with non-invasive PGT compared to invasive PGT. However, we need the concordance to be higher. We need it to be at around 95, 96 before it is clinically applied. However, groups have suggested that with non-invasive PGT, you are getting more DNA from the inner cell mass and not the trophectoderm, which will hopefully give us a much more concrete clinical diagnosis, because we are going to be getting a lot more DNA from the inner cell mass rather than the trophectoderm.
Thank you,
Professor
Dr.
Chang, can I ask a question as well?
Sure, yeah, definitely.
A question for Alpesh. Alpesh, since PGT is evolving so much, how do you make key performance indicators for something like PGT? Because these new techniques are always coming in, especially if you're a clinic whose patient set or group of patients coming to your clinic are primarily for PGT. There are clinics who are known for that around the globe. So how do you set your SOPs and KPIs for that?
It's a very good question, Haroon. It's very difficult to set benchmarks on some key practices such as biopsy because they can be so variable. So for example, one of the KPI that we use for biopsy, because again, from a regulator's perspective, we need to be collecting KPIs. So for the biopsy practitioner, the KPI is what we call re-expansion. So when we're training embryologists for biopsy, we make them biopsy the embryos and then see how many of those embryos re-expand. And when they re-expand, we consider them as survived the biopsy. And that should be over 85 to 90%. Now, I appreciate that clinically, this is difficult to do because the moment you biopsy the embryo, it is collapsed and you then want to vitrify it. So what we then do is we measure that KPI at thawing. I appreciate at this point, then you have introduced a new variable, which is thawing the embryos. So that may have an impact. But the way we measure KPIs when it comes to biopsy is the percentage of embryos that re-expand post-warming.
And that's
And
excellent
of course,
point.
and of course, the clinical pregnancy rates, etc., etc.
Yes. And there's a question from the audience for Dr. Latif. Should we include a single birth as KPI in ART labs? And meanwhile, some patients in favor of having twins rather than singleton.
So I think it's a very important question, and it's more important in a region where me and Keshav are practicing. Because I was just in a webinar this morning, and we were discussing that most of our patients who come to our clinic want to have twins. They prefer having a multiple pregnancy than having a singleton pregnancy. And there are various reasons for that. And one reason for that is the cost, because obviously patients over here in this part of the world are doing IVF treatments from out of pocket. They're not insured by the government or the insurance companies. So at times they don't have enough money to go through another cycle. So what they need to do is they want twins so that they can complete their family and so on and so forth. But as we all know that obviously a healthy singleton pregnancy is the gold standard. We cannot encourage patients having these multiple pregnancies because they are linked with a lot of complications. So single embryo transfer with a healthy singleton pregnancy is the way to go. And definitely from a clinical point of view, you can set this as a KPI. Around the world, a lot of countries in Europe only allow single embryo transfers till a certain age. So definitely it can be considered a singleton pregnancy can be used as a KPI in your ART program as far as the clinical side is concerned.
Thank you, Dr. Latif. I have a question for Professor Mio. So nowadays, when we get the time-lapse microscope, especially the commercial ones, into our lab, some of the company they provide those, like for example, like K-score or other score, like a ready-to-use the algorithm. Would you recommend just use those as is, or should we develop our own, like a not just algorithm, maybe just some like parameters?
Sorry, please say again.
Oh, yes. So with many companies providing the ready-to-use algorithm, for example, like a K-score from the embryo scope, and now they have a new IDAR score. Yes, and would you recommend just use those as is, or should we develop our own in our lab?
どれか推薦するって。
その業者が売ってるのをそのまま使っていいのか、それとも自分たちで何か作った方がいいのか。
Yeah, this is quite difficult situation, but I think we don't use the time-lapse incubator developed by ourselves, because our developed time-lapse cinematography is for only research work. So we use commercially available time incubator equipped with time-lapse systems from the several companies. Yeah, so I can't say anymore.
Yeah, thank you, Professor Mio. So
can I
yes,
just add to the answer here?
Yes.
So
yes.
I think the challenge that arises here is that these scoring systems were actually developed at certain culture conditions, which really need to be mimicked into the laboratory, and that's when you would get like the same kind of environment. So especially like in laboratories where the concentrations might vary, where like they're at a higher altitude or something like that, in those labs it might be a challenge. But generally speaking, like I'll just talk a little bit about the kids score. It generally tells us like kids score 1 is a very fast growing embryo, kids score 2 is a slow growing embryo, kids score 3 is fast and irregular, kids score 4 is slow and irregular, and 5 is the best one. In normal culture conditions, at normal culture parameters, if you're maintaining the same oxygen tension, if you're using the same kind of medias, which we generally are, I really don't think that it should be that different, and we could be using the same scoring systems. I have a time lapse in my own laboratory. I use the kids score, but I also use my own morphological assessment, and then use both of those parameters to select the best embryo to transfer.
Great. Yeah. So, here's a question I would like to ask all of you. So every week I face this like a decision making, wait or not wait on day 5. So if we see a day 5, you know, for top quality or the worst quality embryos, those are easy choices. But how about the fair ones, like early on day 5? Should I wait to freeze till like a day 6 or day 7, or I will go ahead? And also for biopsy, so Dr. Doshi probably can provide some advice on should we wait or not wait on freeze and biopsy?
So for the purpose of biopsy, it is always recommended that you need to have more trophectoderm cells. So early blastocysts, anything which is grade 1, should not be biopsied, and we should wait to day 6 before we biopsy. It is important to have a nice cohesive trophectoderm forming before you take the biopsy. Otherwise, what happens is that if the embryo is very early in its blastocele development, if the blastocele cavity is less than 50%, then the embryo will not prepare itself post-biopsy. So in my experience, it's best to wait till day 6 before you biopsy these embryos.
And even for cryopreservation, Alpesh, I feel that if you have like an expanded blastocyst, that might survive much better. Also, you'll have a better assessment of the trophectoderm, you'll have a better assessment of the ICM. And maybe if it's not great, if it's like a C grade, then the decision might also change. So I would prefer like waiting instead of just freezing an early blastocyst.
Agreed, yeah.
I think I agree with both Alpesh and Keshav regarding waiting is better than going in early. However, there's a concern with it, which is it can be workload driven as well. So at times there's so much workload on the embryologists that they really want to just close the case, freeze it, transfer it, biopsy it, whatever needs to be done should be done so that they can move on next case.
Come and work on a Sunday.
I mean, I went to a lab the other day. Biopsy practitioner was not there, so I was called in on day 5 to do a biopsy. Now, clearly, they were, according to me, there were only 2 embryos that were ready to be biopsied, and the other 2 were very early. But I was told that, no, can you just biopsy all the 4 together? Because you're going to come tomorrow again, and you're going to charge us again for that biopsy. So they said, just finish it off in once. And I said, no, I can't, because otherwise these embryos are not going to. So yes, I understand.
Yeah. Professor Mio, regarding the osmolarity increase during the culture, in your slides, you mentioned that we should choose a medium starting like a lower, like a 260 to 270.
Yeah.
So do you think what's the, while the companies will not tell us what they really put into the medium, so what do you think the manufacturers, the components, and also why they make some of them like lower osmolality and some of them higher than the others? So yeah.
Yeah. We are using we are measuring the osmolality before we use from each commercially available media, different media. So if we use to wet incubator, we are using the higher osmolality medium, and when we use the dry incubator equipped with the time-lapse system, we choose the lower osmolality medium. That is our situation.
Mm-hmm. And also, when you open the medium, the osmolality will gradually change when you put it back to the, even in the fridge though. So how long would you recommend the embryologist using the medium? Because I know if the budget is a concern, the labs would tend to keep using that as depleting it.
Yes, I recommend that within 1 week, you should use the 1 bottle of the culture media. Within 1 week.
Yeah, within a week.
Yeah.
So we use a smaller bottle.
Yes.
Yeah, instead of using the big bottles.
Yeah.
10 ml bottles.
Yeah.
There's another question. Yeah, questions keep coming in. For Professor Mio,
Yes.
What is your opinion regarding the statement of myth that moisture helps to carry CO2, penetrates through oil into culture medium and adjust the pH?
Yeah, I don't know exactly, but so far we have checked the relationship between oil type, several type of the oil and osmolality rise. So I've never checked the CO2 penetrate to the into the through the penetrate through oil into the culture media. I'm not checked yet.
Thank you, Professor Mio. And that could be another like a research topic for the audience. Yeah. So it's been almost 2 hours. I really appreciate the great feedback from the audience and those, especially the insights from our panelist speakers. And we have learned a lot. Even myself, I wrote down a lot of notes from the speakers. And usually this is the time for like we are going to the dinner, like going out at the ESHRE, like I will buy a drink for everybody, going out. And unfortunately this year because the pandemic, so we have this virtual platform. Yeah, so I want to thank all the speakers. Yeah, thank you all very much again. Yeah, it's a great talks and great lectures. And those will be available as a recording to all the members. And I would encourage you all the ESHRE members and attendees to keep going to the following webinars. We have a very good webinar series. So I would like to thank everybody. And this is this is a dinner time for Professor Mio, Dr. Malhotra, and Dr. Latif. And I think it's almost already lunchtime over there in London.
Yeah, almost.
Yeah, I'm ready for breakfast.
Yeah.
So, yeah. And I would like to thank Fujifilm Irvine Scientific again for supporting this educational webinar. And also the Jinky and Yanni and all the ESHRE headquarter office people. And without them, we won't have this great webinar. So thank you all for attending this. Have a good day or a good evening.
Hello, everyone. Welcome to Aspire webinar, PGTA Part 1. My name is Dr. Atsushi Tanaka. I am the director of the St. Mal Hospital in Japan and will be the moderator in this session. Professor Santiago Mune from Spain and Professor Yan Wang Shu from China are our presenters in this session. Professor Mune talked about the PGTA in his presentation titled, "Are aneuploidy rate affected by ALT practice?" He points out the limitations of actual PGTA in terms of inconsistency of doctor's skill for embryo biopsy, control ovarian stimulation method, follicular size, and ovarian conditions. So he recommends metabolomics to overcome the drawbacks of current PGTA and automated art procedures to decrease the repetitive and error-prone aspect of ART. Professor Shu talked about PGTA in her presentation titled, "Using PGTA wisely when and how." She analyzes the current condition in China from the clinical point of view. She insists that PGTA is beneficial to patients who are suffering from the repeated miscarriages due to advanced maternal age, if it is performed with highly required skill for embryo biopsy and cryopreservation. But she also points out that PGTA has not yet been established and many challenges still remain. Please enjoy Aspire webinar. I'm sure you will find a new perspective of PGTA if you join us. We are looking forward to seeing you soon. Thank you.